So just the first thing, I mean, contraception is such a huge, broad topic. It's also something that is extremely common, something that, I mean, I run across on a daily, if not, or weekly, if not daily basis, in talking with patients, but also I think it's very timely. I think this is something that is being talked about more in the public sphere and with news and media, and something that is really important for us to just always kind of keep up to date and keep talking with our patients about it and keeping it at the forefront of our mind. One thing that I always like to think about too is how we're presenting options. So, contraceptive counseling is something that we do all the time. I will often have people who come to me asking for a certain method or saying that they kind of know what they want already. But I also have people who say, I have no idea. And then we kind of go through the all of the options, which can be overwhelming at times. And so it's often, us kind of making that decision. Should we present every single option to the patient, or should we kind of make recommendations or see what their goals are? And there are often these charts or things that are given to patients, but also to us as learners and providers. And a lot of the times it's highlighting effectiveness. So on the left here, it's this graphic that shows the risk of becoming pregnant out of like 100 people per year. And I think that's a pretty cool graphic for people. Also, over here on the right, it kind of has this tier of like least to most effective. This is super common, but I also think that we should be cautious with these types of graphics or the ways that we present things, because I think that can sometimes bias or sway people when it may not be the right method for them. And that kind of leads into my next thing, which is a lot of words on the slide, but this came from the CDC selected practice recommendations from 2024 from last year. And this entire set of this statement was in that document. And I thought it was so great that I actually just want to read the whole thing to you, because I thought it was pretty standout that they put this in there at all. So the CDC acknowledges the paramount importance of personal autonomy in contraceptive decision making. This is critically important because the context of historical and ongoing contraceptive coercion and reproductive mistreatment in the United States, especially among communities that have been marginalized, including human rights violations such as forced sterilization and enrollment in contraceptive trials without informed consent. Coercive practices in the healthcare system can include provider bias for certain contraceptive methods over a patient's reproductive goals and preferences, lack of person-centered counseling and support, or policies or incentives for the uptake of certain contraceptive methods. For healthcare providers and the settings in which they work, it is important to acknowledge the structural systems that drive inequities, such as discrimination based on race, ethnicity, disability, sex, gender, and sexual orientation, work to mitigate harmful impacts, and recognize that provider bias, unconscious or explicit, might affect contraceptive counseling and provision of services. All persons seeking contraceptive care need access to appropriate counseling and services that support the person's values, goals, and reproductive autonomy. Healthcare providers can provide the contraceptive needs of all persons by using a person-centered framework and recognizing the many factors that influence individual decision-making about contraception. I really liked that. I thought it was a good reminder for me, but also pretty great that the CDC kind of made a statement about it. And this was 2024, so before some of the more recent changes to the CDC website and things that are available to us, but this is still there. And I think it's incredibly important to remind ourselves and to remind all of us who are involved in patient care. So I think this is a really important thing for prescribers to think about. And oftentimes we may be the ones who are doing the majority of like the counseling and helping people make decisions. But I think this also filters down into other people who are involved. So absolutely, like everyone else who's seeing that patient that day in clinic, whether it's reception, people who are helping to check out after the visit, or nursing staff, medical assistants, and importantly, also pharmacy. I think this is something that we have thought about with pharmacy, which is the place that our patients are getting a lot of these types of contraception and things that are available or not available or discrimination that they may face. And I think it's on us and our responsibility to address those things for ourselves so that we can provide better care to our patients. And then this also addresses the AHEC value of, health equity, trying to promote health equity and address bias. And so hopefully I'll be able to address some of those things in my talk as well. These are just some resources that probably a lot of you already know about, but are super helpful, especially for people who may not be talking about this every single day with your patients, and you want to make sure you have something to refer back to when you do have these conversations. And so for providers, the CDC contraception app is amazing. In the middle here is the icon when you look it up in the App Store. And then on the right is kind of a screenshot. I think it's a little outdated at this point. This is from the 2016 one, but it looks about the same. And you can look at the medical eligibility criteria by condition or by method. And it also has the selected practice guidelines in there as well. And then for patients, the CDC has a lot of information that's written specifically for patients as well. I think that's a great resource, but I also, again, in light of recent things, should highlight some other resources for patients, such as the Reproductive Health Access Project and Planned Parenthood. So on the RHAP website, if people have not used this, it's great, it's free, it is evidence-based and doesn't have any like financial association with any of these methods. And they have things that are great for patients. So they have a lot of documents or things that you can print off for your patients. And then you can also direct them directly to the website. But I do think that having things that you can print off for people has been really helpful. And the thing that I really like about this one specifically, the Your Birth Control Choices one, is that it's available in a lot of different languages. And it's beyond, just English and Spanish. There are a lot of languages that they have it translated into. And that's kind of what it looks like, but it's much bigger. I think it's 2 pages. And then the Planned Parenthood website, I also really like. And I think what they do very differently is that they kind of highlight maybe a couple of the most common values that people have when they're thinking about contraception. And that allows people to kind of narrow down and not be so overwhelmed by all their options. And then just diving into the 2024 updates for the medical eligibility criteria for contraceptive use. This is a huge document. There's a reason why the app, I think, is way more helpful than the document, but you can use it. And I'm not going to go through everything because it's a huge document, but I think highlighting the updates from 2016, the first one is that the vaginal pH modulator was added, which is the brand name Phexxi. You may have seen pharmaceutical ads for it, and it was added to the spermicide category. But of note, if certain medical conditions have a level of risk, it may be different between this vaginal pH modulator and other spermicides. And then they added chronic kidney disease, which surprisingly was not its own category. And specifically, if the person has current nephrotic syndrome or is on dialysis, you definitely want to be looking at which options would be safe for them. And then they updated several recommendations for Depo, and the Depo shot does have some risk for some of these conditions. I highlighted some of the ones that they had updated recommendations for. And so I will just keep it in my practice to just anyone who is thinking about doing the Depo shot and they have any medical condition at all, I'll probably refer back to this to make sure that I'm doing the safest thing for them. And then the selected practice recommendations for contraceptive use, the updates from the last version were that they talked about lidocaine for IUD insertion. They highlighted 2 sections, one section looking at paracervical blocks, and then another section looking at topical lidocaine application. And for both of them, they looked at randomized controlled trials. There were a lot more trials for the paracervical blocks than the topical lidocaine. And both of them did have at least one, if not multiple studies that showed that it may reduce patients' pain during the procedure. But there were other studies that didn't necessarily show that. But they often didn't show that there were any harms. So I think that the consensus based on these guidelines is that it might be beneficial for IUD insertion, but it's a provider to provider preference because it's not overwhelmingly convincing. Misoprostol has been looked at a lot to see if that would help with discomfort or just ease and success of IUD insertion. And in general, the consensus is that it is not useful for routine insertions, but there have been some studies that show benefit if it's used after a failed insertion. And you typically pre-treat with vaginal misoprostol, and you will do 200 micrograms the night before, and then you do a couple hours before you do another dose, and it may be beneficial. It also talked about management strategies for abnormal uterine bleeding with specifically the Nexplanon and IUDs, and I'll talk about that later. And then it mentioned that testosterone may not prevent pregnancy entirely, and so we should be sure to be counseling and offering additional methods. And it also highlighted that self-administered Depo is safe and effective and should be offered as an alternative. So now I'm going to kind of go by method and just go over some of these things that likely will be a review for a lot of people, but then some things that are updates from the past several years. And so some things may be really new and some things may be known by most of you. So starting with pills, we have the combined hormonal contraceptives and the progesterone-only pills. I do use a lot of acronyms in this talk, but hopefully with context, you won't get too lost. Generally, it is also recommended that we do quick start, and that when patients come in, we tell them that they can start right away. If people would prefer to do it starting on Sunday or starting, at a different time, they can. I just think that our recommendation should be that they can, there's no barrier and that they should start as soon as that day. And then that they should use a backup method for the first 7 days. We should also be providing a year of prescription. So that can be in the form of, just monthly and with 11 refills, or 3 months or 6 months at a time. And sometimes that can be state dependent or insurance dependent, whether they may cover 6 months at a time, but trying to encourage that for our patients so that there are decreased barriers. And then also just to review, a lot of these pills come in the standard cyclic method where you take the either 3 or 3.5 weeks of active pills, you have a withdrawal bleed for those placebo pills, and you start the next pack. But more and more, we're using extended cycle or continuous use. So extended cycle meaning you do not take the placebo pills, you continue on to the next pack right away, but that you would schedule withdrawal bleeds potentially like 3 or 4 times a year, versus continuous use, which has been proven to be safe and effective, where people are only taking active pills and they do not take any placebo pills. I will say anecdotally, there are more people who have breakthrough bleeding, which we'll address later too about how to manage that. And then another thing to note, there are these different types of pills. So some of them come in these 21 days of active pills, 7 days of placebo pills, and then other ones are 24 and 4. And I think we should be making sure that we know exactly what we are prescribing or what they have, so that if we're giving counseling about, especially if we're doing the extended cycle or continuous use, that we are giving people the correct counseling, so then they go home and they're looking at their pills and not confused. And then just specifically talking about the combined pills. So review of the type of estrogen, all of them these days have ethinyl estradiol, and they do have differing dosages. And I think that's something to consider in our patients. The lower dose tends to be the 20 micrograms, up to 30 or 35 is the higher dose ones. And the higher dose does reduce breakthrough bleeding. So if someone is on the low dose pill, then and they're having breakthrough bleeding, you may switch them to a higher dose of the estrogen. And then the type of progestin, I think, is also something that can be really overwhelming for folks to think about and to kind of think about, do I need to choose one over the other for my patients? And this is a little bit of an overwhelming table, but on the left, it talks about the different generations of progestins and their different receptors and kind of their activity against these receptors. And the most common one that I feel like I see is the second generation levonorgestrel, which is also the same progestin that is in our hormonal IUDs. But I also do see some of this one, or the drospirenone is the Yaz or Yasmin, and these are the fourth generation, the slightly newer ones, and these tend to have the most kind of anti-androgenic possibility, although everyone responds a little bit differently. So over here on the right, there is this table about kind of the theoretical side effects relating to physiologic activity at these receptors. I think this is a lot of things to think about, and it's very interesting. But what does this mean in clinical practice? Probably not a whole lot. So they did a study of almost 3,000 French women in the early 2000s. So I think this was before Yaz and Yasmin were being used quite as often, but in general, all of the other generations had been around and being used. And this study showed insufficient data to support a difference in tolerance or side effects among the different combined hormonal contraceptive pills. So what I take away from that is that we probably should have a couple different ones that we use, probably have one that's kind of our standard or go-to for a lot of people. That is the levonorgestrel one. And then if people are coming in and they're complaining of symptoms like breakthrough bleeding, or they're complaining of other things like other symptoms, trying a different one and maybe having a little bit of a thought about, should I have one that's more anti-androgenic? Should I have one that has a different type of progestin? Is probably the most useful way to look at it. And then talking about the progestin-only pills. So a cool update was that there was the first FDA-approved over-the-counter oral contraceptive pill that came out, and it started being in stores last year. It's called the O-Pill. It is a 28-day pill pack without placebo. Oftentimes you can get it in the store as like a 28 days, or you can get 3 in a pack. There's no age restriction to get this in the store, and it obviously doesn't need a prescription. It is about $20 a month, although on their website they have kind of a subscription model where you can get a 6-month supply and you get a discount for that. The typical use effectiveness is in the low 90s, but that's a lot higher than other non-prescription methods like condoms, withdrawal method, fertility awareness. So I think it's still an amazing thing that we have to offer. I think for most of our patients, it's not the right option because we can get them prescriptions or other methods for cheaper out-of-pocket costs. But for some people who either there's a barrier to being seen by a clinician, or they don't want any records being of things like, specifically, I'm thinking about minors. These things are available, which is pretty cool. In general, though, these have a narrow dosing window like all progestin-only pills and must be taken within 3 days of the prior day's dose to be maximally effective and to minimize extra bleeding. But there was also a new separate type of progestin-only pill called Slynd, which has now come out. It is a different type of progestin, so it's drospirenone, and it has an improved window. So you can take it with more flexibility up to 24 hours after, really 48 hours after the last dose, and it will still work, although people really should be still taking it around every 24 hours. And this one, the only thing to know about this is that it has some anti-mineralocorticoid activity This is the same as Yaz and Yasmin. So the same thing applies where if you have a patient who has another reason to have hyperkalemia, like they have renal impairment, then you want to be really careful with these medications. You can still use them, but you want to check their electrolytes. Few quick words on the patch and the ring. I feel like I don't see these being chosen or used by patients as often, but they can be really good options for some folks. They're a good option for people who may have a hard time remembering to take a pill and potentially if they experience nausea with the pills, but they still want a combined method. The downsides is that they can be expensive, especially the NuvaRing, and there's also the Annovera ring. These can be expensive and out of pocket, they can be definitely prohibitively expensive. There's the potential side effect of increased vaginal discharge with the ring. And then with the patch, often people will discontinue using them because of skin irritation or just difficulty keeping them in place because they start to peel off. And then if they start to peel off, not only is it annoying, but it can be not effective. Talking about the depot, just to review, this can be used up to every 13 weeks. So a lot of times we have people come in every 3 months. Technically, the interval looking at weeks should be 13 weeks. It has been linked to decreased bone density if used for longer than 2 years. And I think this was a kind of big study, big finding that came out a few years ago, several years ago, and we started to be nervous about using Depo. And I think there was a lot of counseling on people to say, oftentimes this is a good intermediate method, like it's a great method for postpartum, but trying to get people off of it or using a different method if they're using it for 2 years. But there have been updated studies that show that this decreased bone density is probably reversible. So you can counsel your patients about this. And if it really worked for them and they want to continue beyond 2 years, I think that's shared decision making. And then, as I said before, there's these new recommendations from the CDC and the WHO that self-administered Depo should be made available as an alternative because it has equivalent rates of pregnancy, side effects, and adverse events compared to it being administered in the clinic. So I think this is a cool thing that we can offer to our patients. I probably don't see this being used super often, but again, for those small subset of people where coming into clinic is a barrier to care, this may be able to address that barrier. Now moving on to our favorite, the LARCs. So just a review, because the duration of effectiveness has certainly changed since these came out. So starting with the Nexplanon, just to review, FDA approved for 3 years, but it's likely effective for 5. And that is how I counsel patients and tell them that they can come in and get it removed and replaced in 5 years. We'll talk a little bit more about maybe what that means for removal, but the Mirena and Liletta are the brand names for the levonorgestrel 52 milligrams, or like the highest dose ones. And those ones are both FDA approved and effective based on studies for 8 years. The Paragard, the copper IUD, is approved for 10 years, but based on studies, it's likely effective for 12. The Kyleena is one of the smaller IUDs that has less of the levonorgestrel in it, and it's approved for 5 years. And the Skyla is the smallest, and it is approved for 3 years. The implant, or Nexplanon, just to review some things about insertion, I'm seeing a lot of people recently getting the Nexplanon. And I think it's awesome because it's a very quick in-office procedure. And generally, it's one that patients can come in, we can do counseling on it, and then put it in that same day because it's just so quick and easy. But I will say that local anesthesia is essential. It feels silly that I have to mention this, but I had a recent experience with a patient where they said that they did not receive any numbing and they had their Nexplanon inserted. And that happened in the state of Idaho. So I just feel like I should mention it. It is the standard of care. And based on the Nexplanon training guidelines, it specifically says that you can use topical numbing, like a numbing spray, or um, injected lidocaine. Either one is technically okay, standard of care, but I would say far and away the lidocaine works better. And the no touch technique is great. Again, it also makes it very fast and quick and easy. You don't need sterile gloves. And making sure that you're checking that the rod is in the applicator prior to insertion and then palpating immediately after to confirm, again, as part of the standard of care. And we do want to make sure that we have told our patients that this is something that will protect against pregnancy. But if there is something wrong with the applicator, which does happen, it has happened to me, then we are doing a disservice to our patient and there could be an unintended pregnancy. Um, and then the biggest thing that people complain about is the bruising and potential for hematoma formation. And so the best things for that are a good pressure bandage and then they can ice at home. Removal is one of the biggest things that I wanted to talk about because I think these are awesome, super quick and easy to put in, but taking them out can sometimes be tricky. And generally, you could, if you're coming into issues, some of them pop out really easily, but some of them take a while. And so you may need to have some extra time dedicated to that. And the longer that they are in, sometimes it means the more scar tissue, the kind of harder that capsule is around the Nexplanon, and it may make it more difficult. So I wonder, if we are starting to see some more of these difficult removals due to patients leaving them in for 5 years. The first thing to do if you are unable to palpate or if it's really difficult to palpate, the first thing that you should do is ultrasound. And luckily they show up pretty easily on ultrasound. And then you can confirm the location and the depth, which also helps you to think about, is this something that is safe for me to do or not? But for a routine removal, another tip is to inject lidocaine underneath the tip of the implant. So if you are pressing down on one end to kind of flip the other end up, then you can do that while you're injecting the lidocaine underneath the tip of that implant, the side that you are going to be trying to remove first, and that can help to raise it up and also minimize distortion of the overlying tissue. The pop-out technique is the least invasive, and I think it's awesome. So I have the next slide to show you, and there's a really quick video on the RHAP website that you can review prior to, if this is not the way that you were taught, but you want to try it out, I highly recommend this video. But if only the middle of the implant is the easiest to feel, like you can't quite get one under the other, then you can still attempt to remove it that way through the center, but ideally a VAS clamp would be super helpful. They are really great to just grab right onto the middle of the implant, raise it to the surface, and then you can dissect over it. If you don't have a VAS clamp, then a small curved hemostat or a skin hook can also be used. And this is the pop-out method. So like I said, the RHAP website has a great video on this. And so these are screenshots from it. On the top left is, this finger position where on this side, they are pushing down on that proximal end of the Nexplanon. And over here with their thumb, they're kind of having their thumb underneath it to keep it in place and to kind of raise it up a little bit. And then after you've injected your lidocaine, you do a stab incision right over where it's about to poke out. And then you basically just use that scalpel to make some hatch marks and start to cut away at the capsule that is around the Nexplanon. And ideally, once you do that, then once you've broken through the capsule, it just pops out because you're keeping pressure on it with your index finger. And so on the right here, it has popped out, and then it's popped out enough, and you can push it with your index finger of the left hand, push it out, and then you just grab it with your fingers, and you don't need anything except for a scalpel, which is awesome. But obviously, that's the ideal situation, and it doesn't always happen that way. Moving on to IUDs and IUD insertion. This is a big topic, and I think this is a big topic in our education, but also again in when it comes to the public sphere, social media. There have been more and more conversations that are being had by patients about their experience. And I think it is a wonderful thing because I think more and more people are talking about contraception and also talking about IUDs. And they're a lot more common now. But I think it's also hard because I think there are some people who are hearing about some really traumatic experiences and then they come in and they want it, but they are really anxious and concerned about the experience, or there are people who really don't want one because of hearing about these experiences. So the first thing that I want to talk about is just patient discomfort and anxiety. And I think there's been a lot of movement on what can we do and tips for that. The first thing, ideally, is people are taking ibuprofen 600 to 800 milligrams 30 to 60 minutes prior to the procedure. Oftentimes, the way I counsel patients is to take it like 20 or 30 minutes before they arrive for their appointment. So then by that time, it gives a little extra time by the time they're roomed and we get ready. It may or may not actually help for the procedural pain. The best thing that it helps for is cramping after the procedure, and I do counsel patients on that as well. The other things are topical lidocaine spray or gel. It has been potentially proven to help with the pain, mainly for the tenaculum placement, because there are some patients who really don't feel the tenaculum very much, and then there's other patients who that's a very painful part of the procedure for them. And then a paracervical block. And specifically, the studies that have had the best results have been using buffered lidocaine, which is not something that I tend to do, but I think it's something that in preparing for this talk, really made me think about my process and thinking about that for the future. Paracervical block, typically if you're going to do that, then I would also pair it with a cervical block in the site for the tenaculum placement, as well as either, you can do 4 injections at 2 o'clock, 4 o'clock, 8 o'clock, 7 or 8 o'clock, and 10 o'clock, or you can do just the bottom 2, which is, I would say, more common. And then the other thing that you could consider, again, if there are some people where the tenaculum is a really hard part of the exam, is doing an insertion without a tenaculum, although that really depends on the patient's anatomy, provider comfort, and ability to get through the cervix, or very, very slow application of the tenaculum. So this is not something that's evidence-based, but is coming from experienced providers, and it has been helpful in minimizing pain. And it's like very slow application, like taking, 5 or 10 seconds to close the tenaculum. The other thing that can be offered is an anxiolytic like lorazepam. This is something that I have a low threshold of doing these days for patients who come in and they are extremely anxious about the procedure. However, you must have a driver. They must have a driver, and it means that you have to have the consultation beforehand, have them get the prescription, pick it up, and take it prior to the procedure. So it may be a barrier. And then the other things are just non-pharmacologic things. So this is stuff like having a trauma-informed practice, or which I think is a whole other talk in itself. And I think that is kind of the onus is on us a little bit more to seek out those those instructions on kind of how to be trauma informed, but it can make a huge difference for all of our patients. And I think if we get into the habit of doing it for every patient, then we can minimize these traumatic experiences, and also help, we're prepared to do that when there are patients that come in saying that they already know that they're going to have trouble with this. Also counseling on patient autonomy. So before the procedure, saying that they are in charge, that they can tell us to stop at any time, and listening to them when they ask for that, when they ask for a break or to stop. Vocal, local, or just talking to your patient through the procedure. I think that's something that is sometimes hard for us to do when we're down at the end of the bed and not really making eye contact. But it's super useful to have another person in there who can help to provide that. And then other things that actually have been studied are having music, it's like soft lighting, having a support person, or having heating pads, which again, I think is something that sometimes in our busy clinic schedule, we don't always make a huge priority. But at least in our clinic, we recently got dimmers inside the clinic room, and I think that's awesome. So I'm going to be using that. And then just some other things for IUD insertion. So thinking about positioning can really help with your success. So you want to make sure that you're increasing the pelvic tilt, and the first thing to do is just always asking the patient to just scooch down until they're really kind of hanging almost off of the bed, so that you can improve the ability to like access the uterus and the cervix. And then, as I talked about before, trauma-informed counseling, coaching during the procedure, and having an assistant to help at the patient's side so that there's someone who's able to be up there maintaining eye contact, but also looking at the patient and being able to see if we need to take a break. And then the cervical stenosis is another thing that we come across, and having os finders in the clinic, which is the middle three, or having cervical dilators. So especially using the top cervical dilator here, the 5 and 6, you may end up needing to use that, but usually I would use an os finder first, which applying very, very light pressure so that you don't create a false tract, but just allowing the end of that os finder to find the track, so that then if you do need to use the dilator after that, you know exactly where you're going. Or misoprostol. So if you fail and need to repeat and try again, then you could consider the misoprostol pretreatment. What about STIs? So routine screening is recommended. However, it shouldn't preclude placement. So you can test at the time of placement, and if positive, keep the IUD in place and treat. If you previously have a diagnosis of gonorrhea, chlamydia, you should treat that prior to insertion. And then thinking about our patients who are transgender or non-binary, we really want to take the time to counsel with our patients and to come up with a plan and think about what things they may be anxious about. Using an anxiolytic in these patients can be useful. These procedures can definitely trigger gender dysphoria. And then another note is that prolonged testosterone use may cause vaginal and cervical atrophy. And in those patients, vaginal estradiol may be helpful. Difficult removal is another one. So addressing the same things as placement, but also if the strings are not visible, the first thing is get your algorithm up. So there are algorithms from the AAFP as well as RHAP. And if it sounds like the IUD may have come out based on the history, you want to just go to the ultrasound. Otherwise, you want to use a Cytobrush first, which is the top thing on the right-hand side. And then if the Cytobrush doesn't work, then you're going to want to do an ultrasound and confirm that the IUD is intrauterine and not embedded into the wall. If that's the case, then you go stepwise and you try a thread receiver, which is B over on the right, an IUD hook, which is D. Sometimes looks a little different than that. The alligator forceps, which are E, and I think those take a little bit more familiarity and sometimes can be a little trickier to use, which is why they're farther down. Or you may need to dilate the cervix. So in the middle over on C, you can see the sound slash dilator. Utilize ultrasound guidance during the procedure is possible, or using an MVA if you're someone who already has that skill set. You can use a 5 or 6 cannula, but you will have to dilate first. And then if the IUD is not visible in ultrasound, you want to check a X-ray, and if the IUD is embedded outside of the uterus, or if everything else fails, you should refer them to a gynecologic surgeon. This is just the algorithm. And then what if a patient is pregnant with an IUD in place, which happens? And if pregnancy occurs, there is an increased risk of ectopic pregnancy. The IUD itself doesn't increase the risk of ectopic pregnancy because overall IUDs prevent pregnancy, and so the risk of ectopic pregnancy is much lower. But if a pregnancy occurs, there is an increased risk for ectopic, so you want to be on high alert for that. There's also an increased risk of spontaneous abortion, septic abortion, chorioamnionitis, and preterm delivery if the IUD is in place. Those risks are reduced if the IUD is removed, but not completely. So there's still an increased risk of those things, even if the IUD is removed. However, that is the standard of care. They should be removed if the strings are visible, or you can remove it easily from the cervical canal. If it's going to be more invasive, that needs to be a conversation with your patient. And then the management tips for abnormal uterine bleeding. I'm going to go through this a little more quickly, but basically we see lots of different bleeding irregularities from these methods. And so we'll go through the different methods. The CDC came out with this lovely flow chart that I would encourage you to refer back to. But I'm going to go through what the recommendations are. So for the pills, abnormal uterine bleeding affects 30 to 50% of people who are started on the combined pill during the first 3 to 6 months, but that generally gets better. So that rate improves to about 10% after 3 months of use. So if people are complaining of bleeding during the first 3 to 6 months, oftentimes I'll counsel to try to get through those 3 months to see if it improves. And then if they're getting breakthrough, you can try 4-day hormone-free intervals as needed for those people who are on the continuous or extended cycles. And then people who are just taking the regular cyclic method, they could maybe benefit from the 24 and 4 type of pills instead of the 21 and 7, or switching to a different pill. For the low dose, as I said, going to a higher dose of the estradiol may help. And then with the progestin-only pills, there are more people who deal with irregular bleeding, and this may be due to that narrow window. SLIND appears to have a better bleeding profile, so that is a benefit. For the depot, there is often irregular bleeding, typically improves after use for up to a year, but it may also mean that they have amenorrhea, which for some people is a benefit. For some people, they do not like that. For the implant, this is, I would say, the most important kind of the implant and the IUDs. A lot of people come in and it may be a reason that they want to not use this method, especially with the Nexplanon. And what they have found is that if abnormal bleeding persists beyond 3 months with the Nexplanon, it's unlikely to change beyond that. And so things that you can try are a set of the combined hormonal contraceptives. So give the pill, and usually I would just give basically a 28-day pack. And they can do it it's been studied for just a 10-day course or a 20-day course. Some people just do 1 month worth and then stop. They will, after they stop, get a withdrawal bleed, but after that, sometimes it regulates better. And then you can also try NSAIDs. So you will try scheduled NSAIDs for 5 to 7 days. Typically, the easiest way to do that is to use naproxen, 500 milligrams twice a day. And then if the above is unsuccessful, you could try tranexamic acid for 5 days, and that may help, but it may not have persistent effect. For the hormonal IUD, they may have irregular bleeding and cramping in the first 3 to 6 months, but that, in contrast to the Nexplanon, typically does lessen because there is more endometrial suppression that happens with the IUD versus the Nexplanon. And often this decreases to oligo or amenorrhea, which is more likely to happen with the Mirena and the Layletta, and less likely to happen with the Skyla or Kylena. And so for people who maybe do not want to lose their period completely, the Skyla or Kylena may be a better option for them. And if people have persistent or bothersome bleeding, the first thing to do would probably be checking placement on ultrasound, because non-fundal placement of an IUD has been correlated with higher rates of bleeding at 6 months of use, so beyond that first 3 to 6 months. And it may be a reason to remove and replace. And then another thing is that, in the meantime, in the first 3 to 6 months, you could consider naproxen 500 twice a day for 5 days, as with the Nexplanon, as kind of a temporizing measure. For the copper IUD, as probably a lot of us know, it can often create heavier or longer periods, as well as unscheduled bleeding, about 70% of new users. And there is the chance that that could improve closer to after a year of use, but the amount of people that it improves for is very low. And so I think that is just something that we have to make sure that we're counseling our patients on. The treatment options, again, I think this is not really something where the treatment will be long-term treatment, but you could use scheduled NSAIDs for 5 to 7 days during the bleeding, as we do for just heavy periods in general. Or you could try tranexamic acid. The studies basically show that it may decrease mean blood loss, but we don't really have great data on what that means long term. Is that something that people can use every single time that they bleed forever? And it also won't affect the bleeding pattern. So if they're having irregular bleeding, this won't really help with that problem. And then switching contraceptive methods. I think this is another one where just having the resource, having something to go back to, because there's so many different permutations and so many things to, remember, that there are really helpful tables in the AAFP as well as in RHAP. This is the RHAP version. And you can just go to what you're starting with and what you're going to, and make sure that you're giving the right information to your patients. Most methods take 7 days of consistent use to be considered effective. So if you look through here, most of them will say 7 days, but some of the exceptions to be aware of would be the copper and the Mirena or Layletta IUDs. Those ones are effective as emergency contraception. So if you're switching from something else, they can even work backwards. And so those are ones that you can pretty much just start. And then the depot shot lasts, typically we say that they're effective for 13 weeks, but oftentimes to make sure, especially if you're using something else with progesterone in it, that you start the new method up to 15 weeks after. And then different pill types, so even going from progesterone only to combined, or different types of the combined pills, they can just be stopped and started. And then a couple updates on emergency contraception. So Ella is the prescription, Ulipristal. Plan B is the levonorgestrel one that has been over the counter for a while now. It's nice to be able to give your patients a prescription version if that's something that is covered by their insurance and then is no cost to them. But there's some things to know about the Ella. Ella has a theoretical risk of interaction with progesterone-containing contraception. So if you have a person, well, I'll say that in a second, but basically Ulipristal is a selective progesterone receptor modulator that has a high binding affinity, and so it may reduce the efficacy of those types of contraception, and those types of contraception may affect the efficacy of the Ella. And so if someone takes Ella, they should really wait 5 days before starting the patch pill or ring, or start those things, you know, after they take the Ella, but that they will need a barrier method or some kind of other method for at least 5 days. And then the plan B is a good option if people have unprotected intercourse during a period of, missed pills, patches, or rings. Like if they have recently taken those things that contain progesterone, then probably plan B is more effective than Ella. And another thing for emergency contraception, as I alluded to earlier, the Mirena IUD was non-inferior to a copper IUD in a randomized controlled trial based on 1 month follow-up urine pregnancy tests. So that can also be used as emergency contraception. These are my references, and I would love to hear if anyone has any questions for me.
Thank you, Dr. Hall. I don't see any questions in the chat. Oh, I do. I'm sorry. There is one here. Um,
Oh yeah, I see Ben has a question about a resource for certain combined. Yeah, I don't have a specific resource, honestly, except for Google. I just look up the one that they're on or what I'm planning to prescribe to someone and look for, is there a picture of what the pill looks like? I'm often doing this anyways if I'm counseling people who have never taken the pill before, because I want to explain to them exactly what it looks like. The other thing that's great is that our pharmacists can help us out with that. So our pharmacists can oftentimes like go through and answer questions and show exactly what they should be taking. And especially, I think that's super helpful with using the continuous method. Like if people are going to skip through placebo pills, I love, especially at our clinic, we have our clinical pharmacists who are people that we know, we're very familiar with. So I could even send a message to my pharmacist and say, hey, can you make sure to run this through with our patient? And yeah, nothing except for Google, basically.
are there any other questions for Dr. Hall?
Yeah, and that's Abby. That was an excellent talk. I thought it was really interesting about there is a specific sort of set of instructions about the pop-out method for the Nexplanon, because I think a lot of us just sort of intuitively do that. But I thought that was really great, and that will definitely kind of change my practice about teaching and evidence-based stuff. So thank you for sharing that.
Yeah. Yeah. Thanks for commenting on that. Because I think that, I mean, as with a lot of things, we get sometimes there's very standardized teaching, especially for something like the insertion. Like I feel like we had very specific training for insertion. We had some specific training for removal, but then I've also seen it done different ways, and people have used different types of tools. Like some people will always use a hemostat to grip onto the end of it, but you do want to be careful that you are making sure that you're getting all of it and that you're not kind of taking a chunk out of it. So I really liked that method. Also, the video was just like, it went so smoothly and it looked so nice. So it's always fun to see.